Hi, everybody. This week we talked about mental health. We talked about a bunch of different psychiatric disorders and how we would approach them in primary care. Um, Psychiatric conditions, psychiatric health is something that I take very seriously, as we all should. And it's probably one of the more intimidating topics for me. I never want to be the cause for somebody's worsening mental health, not doing enough for somebody. I certainly don't want to be the reason that, God forbid, somebody, has a suicidal attempt. So there's a lot of weight on the decisions that you make regarding caring for somebody's mental health. I know we talked about it a little bit in the 15-minute hour, but I just wanted to spend just another minute or two talking about the importance of your documentation, about the questions that you ask, and about the follow-up that you have with your patients. Most common psychiatric conditions you're going to encounter, especially in primary care, is going to be depression and anxiety. And even if you're absolutely sure that the patient is having mild symptoms, they're mildly depressed, mildly anxious, that still means that you need to do a risk assessment for suicidal ideation. Um, you know, the patient may be just kind of not giving you the full emphasis on their symptoms and trying to play it off kind of cool, or that it's really not as bad as it really is. So you always want to do that assessment regardless of whether you're sure or not that they have mild symptoms or more severe. And obviously if they have severe symptoms, you're absolutely doing a suicidal risk assessment. By doing that, you kind of open the door for further conversation. So, say for example, I have mild depressive symptoms. By just you asking, well, I hear what you're saying, these are the symptoms that are bothersome to you, whether, anhedonia or you're tired all the time, whatever it may be. I just want to make sure that nothing more serious is going on. So are you having any thoughts of hurting yourself or others? And, you know, most of the time, the patient will say, no, my symptoms are not that bad. I have no intention of harming myself or anybody else. But sometimes that is enough just to open the door for somebody to say, you know, I won't say that I've had those thoughts, but sometimes I go into a really dark place. Or, you know, thank you for asking. Yes, I have had those thoughts. You just open the door to further conversation. So, as scary or intimidating as it might be as a provider to be like, oh God, please, I hope that they're not suicidal, because that's a lot to deal with and I got to make sure they get the right care. And, you still need to ask those questions. And then you need to document that as well. So even if their symptoms are mild or whatever your plan of care is, you always document in your history that you've asked the patient the question and yes or no, whatever their answer may be, because that is, your trail of evidence, your communication to another provider that at that point in time, these are the thoughts they were having. So you always want to document it. And then as far as follow up, you want to, keep a close eye on them, especially, depending on how severe their symptoms are. You may see them every other day till they, get adjusted to a new medication, or at the very least, like 2 weeks after you start them on something. Usually in the beginning, especially with somebody with, more moderate to severe symptoms that I was really concerned about them and I wanted to keep a close eye on them, I would only give them a week or two of medication. Like I would only fill a prescription for 7 pills or 14 pills, whatever it would be. That way, if their mood does change and they do become suicidal, that it won't be the medication that they use to do that. And then it gives them a reason to come back and see you, to come back for more medication. So that's something else you can do too. So even though, the literature will say, close follow-up, maybe at 2 weeks, at 4 weeks, certainly after 6 weeks, once, a lot of antidepressants, for example, have had a chance to really start to work, You don't have to give, you know, a 90-day supply of medication. You can just give a 7-day, 14-day supply and give them a reason to keep coming back. And then if they don't, then that warrants further follow-up and all of that as well. So, just wanted to share a little bit of my experience, you know, especially with managing anxiety and depression. I can certainly be more specific if you'd like, if you have any other questions or anything like that. But it's just so important. You know, mental health has such a stigma in this country. We know that. It takes a lot of courage for patients to come to you with mental health issues and concerns and talk to you about their feelings. So always make them feel valued and that their time, you know, is important and that you really care about what they have to say, and, you know, getting to, you know, what their symptoms are and how you can help them. Um, but I also just wanted to reflect a minute and kind of like from the provider standpoint, it can be kind of intimidating, but very rewarding at the same time. Certainly, as you keep seeing these patients come back and they're doing well and they're, you know, able to live their lives and do the things that they once enjoyed. So it's very rewarding. So anyway, that's my sidebar. I hope you're all doing well, and let me know if you have any questions.